Mirizzi syndrome is a rare but high-yield complication of chronic gallstone disease. It occurs when a gallstone becomes impacted in the cystic duct or the neck of the gallbladder, Hartmann's pouch, causing extrinsic compression of the common hepatic duct, CHD. For your PG exams, the critical takeaway is that it presents like obstructive jaundice, but the blockage is outside the common bile duct itself. 1. Pathophysiology. 1. Impacted stone. A large stone gets stuck in Hartmann's pouch. 2. Extrinsic compression. The stone and the resulting inflammation presses against the adjacent CHD. 3. Fistula formation. Over time, the constant pressure causes the wall between the gallbladder and the CHD to erode, creating a cholecystobiliary fistula. 2. Sendes classification. This is the most common staging system used in surgical exams to determine the extent of the fistula. Type. Description. Type 1. External compression of the CHD by a stone in the cystic duct's neck, no fistula. Type 2. Cholecystobiliary fistula involving less than 1/3 of the CHD circumference. Type 3. Fistula involving 1/3 to 2/3 of the CHD circumference. Type 4. Fistula involving greater than 2/3, complete destruction of the CHD wall. Type 5. Any type, IIV plus a cholecystoenteric fistula, usually with the duodenum. 3. Clinical presentation. Obstructive jaundice, pain, jaundice and sometimes fever, Charcot's triad if cholangitis develops. Labs, elevated conjugated bilirubin and alkaline phosphatase ALP. History, usually a long-standing history of biliary colic or chronic cholecystitis. 4. Diagnosis. USG may show a stone in the neck of the gallbladder and dilated intrahepatic ducts, but the CHD below the stone is of normal caliber. MRCP, the investigation of choice to map the anatomy non-invasively. ERCP, often used for both diagnosis, showing the extrinsic smooth narrowing, and treatment, stenting to decompress the biliary tree before surgery. 5. Surgical management. Mirizzi syndrome is a surgeon's nightmare because the distorted anatomy increases the risk of iatrogenic CBD injury. Type 1. Partial or total cholecystectomy. Type 2 and 3. Cholecystectomy plus closure of the fistula, often using the gallbladder remnant slab plus T-tube placement. Type 4. Requires a biliary enteric anastomosis, usually a Roux-en-Y hepaticojejunostomy. High-yield examples. The trap. During a laparoscopic cholecystectomy, if the cystic duct appears unusually wide or fused to the CBD stop, it might be Mirizzi type 2 IV. Forcing a clip could ligate the entire biliary tree. Association. Mirizzi syndrome is associated with an increased risk of gallbladder carcinoma due to chronic inflammation. Differential. Always rule out a stone inside the CBD, cholelithiasis, or a cholangiocarcinoma, Klatskin tumor.